So good afternoon, everyone. It's a great honor to present this course to you. It's been carefully prepared over months, and we gathered many interesting cases and all the information that we learned from this new technology. And I'd like to thank all the panelists here who took the time, and especially Bob, who, with his innovative mind, and he embraced this new technology, and it's a great privilege to have you here. So this device has not an FDA approval, so this is totally off-label and should be considered as an off-label technology. And this is the structure of our course. We're going to go over every single detail of this simple technique, but yet it deserves attention to many aspects. And this is the new device, which is a supplementary pinhole implant, which was intended for sulcus fixation in a piggyback configuration. It has no refractive power. It's a simple hole, and it's made of a special black foldable acrylic. And it works by the simple pinhole effect, which is well established. And we've been very fortunate to work with a very dedicated team at Morcher, and this study has been going on for the last 4 years. And we've been through different designs, and now we're in the 4th design, and we're going to show cases using all of these devices. And most importantly, this will be available in July of this year, according to the manufacturer. So first, I would like to, these are the numbers here. The first surgery was almost 3 years ago. We've had 32 eyes implanted with all these different designs. And the differences in the designs are ideally, we're trying to find an ideal design that has a gentle contact with the uveal tissue while maintaining excellent centration. So this is our goal. So first I'd like to invite Dr. Bob Morcher to present his experience with this technology.
So let me just begin by saying how embarrassed I am that this room isn't totally full, because this technology is so wonderful, it's so brilliant, it's so clever and so important. But unfortunately, Americans right now are not even using toric lenses. We're going from room to room. I've been in 8 cities in the last 8 Thursdays just teaching people how to put in toric lenses. We're at 10% in the United States and stable. So we're just not advancing like we used to, and it's many reasons. But this, if it's ever allowed in the United States, then you'll see that this room will be much bigger and packed with people in every seat. But right now, as I said, I apologize that people don't appreciate. Part of this syndrome is NIH. NIH is a very important institution in the United States. It's our big health institution, but NIH also stands for Not Invented Here. So if we had invented this here, and if it was approved, you would be in the biggest room of the entire ballroom. I mean, the entire complex. So having stated that, and not just because your family is such good friends of mine, but this to me was the best innovation, and I wasn't the only one who thought of that. Claudio actually received from MIT the Top Innovators Award, or some such wonderful award last year, because they understand. And American ophthalmologists will also understand. We're just a little slow. So it will take some time, but it will happen. So I'm going to show you my lady, which absolutely showed me the light. And I'm still amazed every time I see this lady, and I'm so grateful to you for coming up with the idea. So let's put the video on, please. This is a lady who had radial keratotomy in the 1990s. And she was left with a mess. She wasn't my patient, but there's stitches in her cornea, and she has 11 diopters of astigmatism. It's a terrible cornea. And she's a very smart lady. She was a teacher before her radial keratotomy, and since then she's not been able to leave her house. She's so immobilized by her glare. So I took her to the operating room, and I went ahead and, like I would do any patient with 11 diopters astigmatism, I put in a 28 diopter T9 ASCRS lens, which I realize only corrects 4 diopters, but her surgery went really well. You can see the thermodots there. And on the first day after surgery, to my shock, she could read some of the near card. The good news was her astigmatism had dropped to 2 diopters, 2, from 11 to 2, with an RK cornea. Unfortunately, she now had 6 diopters of myopia. So I wasn't sure what to do about her, and I just happened to be at the Brazilian Film Festival, where I'm happy to say I came in second place to Claudio. Well, I wasn't happy then, because there was a cash award. But yeah, I appropriately so, and here was what he showed me. And he showed that this would fit into the sulcus as a piggyback concept. This was part of his video. The edges were rounded as opposed to the sharp acrylic of an ASCRS. There was a vault to keep the lens away from the iris. But the most brilliant, amazing thing, which still amazes my retina team, my 9 retina guys just love to see this patient because they can't believe this. It blocks light, but it's visible to infrared. You can see right through, so therefore you can use the infrared on the Heidelberg, and you can see the fundus. It's just so clever. It's so brilliant. And Claudio allowed me to take this back to Cincinnati in my shorts, where there's been same shorts that I use, the endocapsular ring and the prosthetic iris devices and the trypan blue from Brazil and everything else. And I took this lens back, and I didn't know whether I should just put it over this lens that's already there with a -6 +2 refractive error, or whether I should exchange the lens. And Claudio helped me, but Warren Hill was my Bible. And Warren said to me, take the lens out. And I didn't know how to take the lens exactly out under a radial keratotomy cornea. I have 2 favorite techniques. One is the Paul Ernst technique, and the other is the Japanese technique from Shuichiro Iguchi, and that was where you take a quarter of the lens out, and then we just rotate the other quarter, and then a 90-degree shift, and the other 90 degrees comes out that small incision. Very clever technique from Shuichiro Iguchi. And then I exchanged the lens. I filled the eye with OVD, and I put in a +22.5. Warren was actually leaning toward a 23, but I didn't want to leave her nearsighted again. So I came out with a 22.5 T9. And I oriented it using the thermodots because I don't like ink. I took out the OVD from behind the lens, and then I put more OVD in front, oriented the see the thermodots up there? You can see the big dot on the conjunctiva, and that one below as well, not subtle. And then I expanded the sulcus with OVD. And we didn't have a shooter like you have in Brazil. I tried every shooter, and I couldn't get a lens to work with the shooter in the United States. So I folded it, and I just enlarged the incision a little bit. You actually gave me 2 lenses, if I remember right, ones that I could practice with. But I think you told me you used the Metafocus. Is that the right injector?
Metacell.
Metacell, yeah. So I wasn't able to use it, and this was the way I put the lens in. And of course, I had no idea what I was doing. I had practiced in a cadaver eye multiple times But when I actually got into the operating room, it was one of those days where you don't sleep the night before with fear and excitement at the same time. So I lined up the pinhole lens, and I went underneath it to take out the OVD because I didn't want intralenticular opacification or a pressure spike or an osmotic gradient with a capsular block. And here's the eye at the end of the surgery inside the incision. So here we are the day after surgery. The lady is, I know you're not going to believe this, but she was uncorrected at 20/40. It was one of the miracles in my career. It was unbelievable. And I followed her, and she has changed her astigmatism a little bit more. She has a little more astigmatism now. She started out with 2, and now she's back to about 4. But still thrilled. She did describe a new phenomenon for me. She says that in certain light conditions, she can see a circle, a silver circle. She's very happy with less glare, but that silver circle was of concern to her. I called Claudio, and Claudio says, that's from the thick edge, and the next thing I know is he had redesigned the lens so that optic would come down and taper to the pinhole, getting rid of that thickness. So if you explain something to Claudio, before you hang up the phone, he's already fixed it. And then the next thing I knew is that that model was no longer his preference. And every time I talk to him, the lens continues to evolve and make progress. So my experience was 99% wonderful and 1% traumatic. It was traumatic to me because I had never put this lens in. Without a shooter, I had to enlarge the incision. Her high astigmatism was already crazy from the RK, and I wasn't quite sure what we would turn out with. But the result was spectacular. And she is a very, very grateful, happy, appreciative patient. So I congratulate Claudio and the Trindaggi family. They continue to innovate, and I promise you, I'm certain that when this lens is approved in the United States, their speakers won't even be able to get to the podium. It will be so crowded. So I apologize for the lack of people here today, but I congratulate you on a great innovation to cataract surgery. I will also leave, I have to depart, but I'm going to leave a couple of video journal things here. On the back it shows you how you can get to the website, and there's a number here, 4847. You can watch every issue. And we did publish this, was it last year?
It was
14. We published it 2 years ago. That's how cutting edge the video journal is. And then I'll leave just a couple of these here as well. We're about our Florida course, which is 600 ophthalmologists that sells out every year. And Claudio's father, Fernando, was one of our guests of honor. This is an amazing course with Doug Koch and Dick McCool and Warren Hill and Ike Ahmed and Lisa Arbisser and Mike Snyder. It is a phenomenal course where we teach from dawn till dusk. So if you'd like information on that, I'll leave a few of these through. And Claudio, congratulations.
Thank you.
It's my pleasure.
Thank you, Bob, for just being here. I know you have several lectures here at this afternoon, and it's for us, it's amazingly important to have you here, and you contributed to this improvement that we've had over the past years. And I just, before you leave, just want to show you this upgrade that we had. See in this left-hand picture, you can see the thickness of the pinhole, the entrance. It's 350 micron as opposed to the right-hand side where we have a 100 micron. And this reduced completely this report of circular reflections that we attributed to the mirroring effect of the inside wall of the pinhole. So your report was important for that, and also the injection system, as I will present, was improved by your contribution. So thank you again for all your innovations and your contribution to this project.
I'm honored that you allowed me to do it, and I'm even happier that you're now going to call it the Osher lens. Thank you very much for that.
So this optical phenomena of circular reflections vanished after this upgrade of reduction of the thickness of the pinhole wall. And as we all know, this is not a new principle. This is actually an ancient principle, which was first described by this Chinese philosopher, Mo Ti, also known as Mo Zi, in the 5th century before Christ. This was the earliest description of pinhole optics, and after it was studied by Leonardo da Vinci later on. And this is used by doctors and patients. Maybe some of you here might be squinting a little to see a little better. And so this is what makes this technology very well accepted by patients. And it's not seen as any adventurous new device, and it's a very well-established principle. And the greatest motivation for this new technology, no doubt, was this raising incidence that we see patients with irregular astigmatism after radiokeratotomy. Many of those patients are now reaching cataract age, and it's truly a big challenge. They come with multiple presentations, but they share one thing, that it's a suboptimal optical quality. They don't have good optics, and they have ugly looking topography and several different corneal aberrations, and you name it. They have multiple complaints of glare, and especially terrible night vision. And so this is, for me, is a big challenge, and it's a current issue. We see this in every forum, in every debate here. You're probably going to hear something about a post-RK patient, and especially in those aggressive RK cases. Especially this one was performed by Dr. Fyodorov in the 80s, a 32 cut RK, and this patient is now in severe problems. He had only one eye done. He didn't want to do the second eye later, and still he's struggling with this corneal irregularity. And I'm sure that there are many alternatives for the treatment of those patients, including resections, suturing, corneal rings, topo-guided ablation, and contact lens, rigid contact lens. But they all share one common characteristic, which is unpredictability. And they all deserve our attention and should be considered in every patient. But in my eyes, these treatments were sometimes unpredictable. And this is one thing that is different from the pinhole optics, which is it is very predictable. We can do pinhole acuity tests preoperatively. And everyone knows that the pinhole will kill every aberration in every case. And that's a common statement. It's period. No one doubts that. And before we get into more theory, I'd like just to get started with this first case. And by the way, this is the ideal patient, and I'll tell you why. This is a 53-year-old man who had RK many years ago. We can't really describe these incisions as radial. They are almost radial, and with multiple transverse incisions intercepting the radial incisions. And another terrible thing happened to this patient. He had an acute episode of uveitis, which was followed by oral moxifloxacin treatment for a pulmonary illness. And he ended up with this disastrous combination of irregular cornea and a large pupil. And this was a bilateral event, this uveitis with severe iris atrophy, which was already described in the literature as a side effect of oral moxifloxacin. So I just would like to tell you to be aware of this rare but very important condition associated with this antibiotic. So just to summarize, this patient had RK, which led to a very irregular cornea, and many years ago he had this unfortunate event which ended up with a fixed mydriasis. And nowadays he has a cataract which was deteriorating his vision even more. Now he can't see well, he has terrible glare, and he does not stand sunlight. It's a real challenge. So IOL power calculation was already a big challenge because of all the conflicting K readings, but we did our best and we came up with an IOL, and we performed cataract surgery in the usual fashion. And after the implantation of the IOL in the bag, we used the device here being used with a Monarch 3 injection system from Alcon. And we are going to go over injectors and tricks of how to avoid problems here. But this is the result after this simple procedure. The device is being tucked into the sulcus and achieves an excellent centration. We are going to go over with Dr. Liliana Werner over details of sulcus implantation and tolerance to materials and designs. But this is the aspect of the eye the day after. The first day, the patient, he reported a dramatic reduction of light sensitivity and a great improvement in vision too. So this is the ideal patient, and there is one other detail that makes him the ideal patient, which is the dark iris. If you had a light-colored iris, there would be a cosmetic issue, not because of the implant itself, because of the anisocoria. It causes a cosmetic problem preoperatively that should be addressed by time of surgery. So the ideal patient is one with irregular stigmatism, a large pupil that invites aberrations into the eye, and with a dark iris because there wouldn't be any cosmetic problems. And these are the main indications for this device. Most importantly, post-RK, post-penetrating keratoplasty and keratoconus patients. But we can extend these indications to any patients with irregular corneas, such as trauma, post-LASIK, ectasia, or any other optical disturbing phenomena, and pterygium, and any other cause of irregular stigmatism. And even the second group of pseudophakic presbyopia, which has been heavily targeted by the industry, including IOLs with pinhole optics attached to it. But no doubt this first group of irregular stigmatism has been left aside by the industry and represents an unmet need. So these are the main indications of this device. And before we go on, I'd just like to let anyone ask questions, or if anyone wants to comment on any issues, you can stop us and just say it. And so let's go into the pre-op evaluation. This is a relatively low-tech workup, and it's mostly done with a pair of pinhole glasses. And one thing that is important to note here is we shouldn't just do a pinhole acuity test, because that will not separate low-order aberrations from high-order aberrations. And the rationale here is we want to try to separate low-order aberrations from high-order aberrations. So the ideally is you should try to perform your best subjective refraction, and on top of that, add a pinhole glass, a pair of pinhole glasses to see the improvement. And so this is pretty much how we indicate this procedure is based on the observation of the improvement, not just with the pinhole glasses, but with the pinhole on top of a well-performed subjective refraction. And there are some tricks to perform refraction in irregular astigmatism, and we're not going to go very deep into this, but I'd just like to share some tricks. which I consider very important. And sometimes you're able to solve the problems of the patients just by detailed refraction. So the most important thing here, the take-home message, is don't trust autorefractors in those cases, because they will give really conflicting readings, and sometimes they're more confusing than helpful. And there is a big difference between a keratometric astigmatism versus the true refractive astigmatism in those cases. So you shouldn't also trust the K readings as a guide for your astigmatic correction, and they vary in axis and in magnitude. And another important point here is how to measure pupil size, and we're going to go over that in detail. And another important examination that should be performed is UBM. Of course, when you're dealing with an implantation in the sulcus, you don't see where the lens is going to sit. So it is important to scan all that territory and looking for anatomical variations, iris cysts, ciliary cysts, or any other issue. And actually just measuring the sulcus to sulcus diameter is an important information, and ideally should be performed before implantation and even after implantation to check how the haptics are oriented. So I'm sure that everyone is thinking of these four main issues that when we talk about this new technology, everything all the answers are coming from these four fields. And when we say safety of this device, of course we're thinking about UG syndrome, which was described, which is very related to sulcus implantation. And Dr. Liliana is going to go over this. She's an expert in this field, and she's going to give us all the information we need about this, and all the other issues here: night vision because of the restriction of light entrance, the visual field impact, and retinal examination. So this is just an idea to see how the difference between three IOLs, the type 93L, which is the code for this implant, which is the commercial name will be XtraFocus, is the one on the left here with a 250 micron thickness of the haptics, much thinner than the Sulcaflex on the right hand side, and not even comparable to the Acrosoft single piece acrylic in the center. So let's just move on to our second case, which I think it's a very interesting case for this new technology. So this 41-year-old man had a terrible knife accident. He had an extensive corneal laceration. He lost a great amount of iris and had a traumatic cataract, which was operated with good success. But again, this is another combination of irregular astigmatism due to the corneal laceration and a large pupil now because of the iris loss. He had a 20/30 correction, but he said his vision was waxy. He said it was not sharp. So he was not pleased with the vision in this eye. So again, we implanted the device in this eye. And especially in those cases, UBM examination is very important because you want to study the sulcus anatomy that might be, that was certainly traumatized by this accident. And, but again, a very simple implantation. The incision here, a 2.4 incision, which was created posterior to the corneal laceration. And this is the aspect of the eye the day after. And the patient was very happy with the sharpness of his vision. He improved from 20/30 to 20/20, and he says that it made a total difference. So again, this is a very good case because of the corneal irregularity, the large pupil, and the dark iris. So this is the ideal patient again. So I'd like to invite Dr. Liliana to give us an overview of sulcus IOL implantation. Dr. Liliana is an expert in IOLs and does a tremendous job at the Morcher Eye Institute, and I really appreciate your presence.
Thank you. Good afternoon, and thank you very much. It's really a pleasure to be here, participating to this course. And you have my disclosures, and I do not have any direct financial interest in this presentation. So today we are going to make some anatomical considerations on the use of sulcus fixated add-on IOLs. We are going to discuss about interlenticular opacification. We are going to comment about the nature of the material, the hydrophobic versus the hydrophilic nature. We are going to comment about the optimal design characteristics for sulcus fixation. We are going to discuss about the problem of pigmentary dispersion. And at the end, I'm going to present to you some cadaver eye studies that we did using some add-on intraocular lenses. So starting with the issue of interlenticular opacification. So as you probably know, this is the opacification of the opposing surfaces of piggyback intraocular lenses. This led to the explantation of pairs of intraocular lenses that were analyzed in our laboratory. And basically, in all cases that we analyzed, the lenses were three-piece hydrophobic acrylic lenses with a material that has a tacky surface, and these lenses were implanted in the capsular bag via relatively smaller capsular rexes. So what happens here is that you have both lenses inside of the capsular bag, and you have the capsular rexes that has a diameter that's smaller than the diameter of the optic. So you have a space here between the lenses, and at the equatorial region of the capsular bag you have residual lens epithelial cells, and these are the cells that are at the origin of posterior capsular opacification. So in this configuration, instead of the cells growing behind the IOL, the cells may grow in the interlenticular space. It's basically the same type of material, and that's what forms this opacification. So how to prevent that? So you have few options. You can still put both IOLs in the capsular bag via a relatively large capsular rexes, so there will be a fusion between the anterior capsule and the posterior capsule, and the cells in the equatorial region are going to be sequestered. Or you can put one IOL in the bag via a smaller capsular rexes in a very standard way, and then you put the other IOL in the sulcus. So you see here that still the equatorial region of the capsular bag is sequestered. So this is the configuration with such add-on intraocular lenses, which indicates that this problem of interlenticular opacification then is not really observed. So a second point, let us discuss a little bit about material and how you characterize the surface of the material. So you know if it's hydrophobic or hydrophilic by certain characteristics, for example, the measurement of the contact angle in water. So with hydrophobic surfaces, there are sharper angles of contact, so you see that the drop stands up. So you have here a very characteristic image. However, with hydrophilic surfaces, the angles are flatter and you have the drop that spreads out. And there are a lot of comments on the hydrophilic acrylic materials being more friendly to the eye tissues and more biocompatible, and some concerns about putting hydrophobic acrylic lenses in the sulcus and how would be the interaction with the posterior surface of the iris. However, I would like to call your attention to these studies. So here, the authors wanted to compare the hydrophobic characteristics of different hydrophobic acrylic lenses in the market. So he got different lenses and he measured the contact angle in the dry state. Then he put the lenses to hydrate to mimic the intraocular environment, and he measured again the contact angle. So what happened is that in the dry state, all the lenses are quite hydrophobic indeed, as expected. However, after hydration, there is a change towards hydrophilicity, so there is a drop in the contact angle. So the characteristics of the surface, if they are tackier, they are not so tacky anymore. So there is no real concern about hydrophobic acrylic lenses not being biocompatible to the posterior surface of the iris and other tissues. So again, all the hydrophobic acrylic lenses show the same level of hydrophobicity in dry state. However, there are changes in contact angle after hydration. Another important thing, what about the design? So we cannot overemphasize that lenses such as this single-piece hydrophobic acrylic lens, they are not indicated for sulcus implantation. They were created for in-the-bag implantation because of many characteristics, thickness and bulk of the haptics, square optic and haptic edges. The side walls are very unpolished. The haptics are planar. They do not vault the optic posteriorly from the iris. The diameter is up to 13 millimeters, and actually this may be too short for many eyes. And if the haptics do not fully extend, the IOL may decenter. So we comment, Claudio already commented about the UGH syndrome. We analyzed many cases in our laboratory. So basically, if one of the haptics of both haptics are in the sulcus, you can have a lot of problems. And these lenses that were explanted, we analyzed them, and there is a huge pigmentary dispersion on the surface of the lenses. And you can see here the edges are very square, and also they are not polished. So the lens was designed for the bag. And we received from eye-banks cadaver eyes, pseudophakic cadaver eyes, and in some of them we observed the presence of this lens in an asymmetric fixation, so sulcus bag. And by doing very precise pathology, we could observe that with the haptic in the sulcus, you really have important damage to the posterior surface of the iris, and you do not observe this type of things if the haptic is nicely placed inside of the capsular bag. Also, it's important to note that even if the haptics are very thin, like in this three-piece hydrophobic acrylic lens, still in this case, the lens has square edges on the anterior optic surface, and these side walls are not polished. So this lens does not have very good results also in the sulcus in a pigback configuration. So we describe this case with pigmentary glaucoma, and as you can see, a very significant pigmentary dispersion on the surface of the lens. And some authors also think that that lens, that three-piece lens with square edges on the anterior optic surface, could cause the same type of problems in the sulcus, even in a configuration that's not as a supplementary IOL. This is a bit controversial because other authors do not find the same thing. So because of that, we did a study using pseudophakic eyes obtained post-mortem, and we really wanted to compare the pathology of three-piece foldable lenses with square or round anterior optic edges. So we had 13 hydrophobic acrylic lenses, three-piece lenses with the square edge on the anterior optic surface, and 14 lenses that had anterior optic edges that were round and polished. And in this category, we had silicone and hydrophobic acrylic lenses, and basically we're comparing lenses with this major difference here. So we obtained these very rare specimens from eye banks, and we performed the complete analysis in histopathology. And indeed, with the square edges on the anterior optic surface, you can find significant damage to the posterior surface of the iris. You find pigmentary dispersion everywhere in the eye. And the most important finding, because some of the findings may be related to complicated surgery, and that's why the surgeon elected to put the lens in the sulcus in the first place. However, when you find a lot of pigmentary dispersion in the trabecular meshwork, that really indicates that there is a continuous rubbing, a continuous trauma to the posterior surface of the iris. So this being said, what it is appropriate for a sulcus fixation? Ideally, there should be posterior iris clearance, the loops should be angulated posteriorly, they should be thin, the anterior surface should be very smooth with a round, smooth, polished anterior optic edge. The IOL should provide secure fixation, and the size is very important, an optic diameter with a minimum of 6 millimeters and an overall diameter minimum 13 millimeters. And to comment some of the lenses that are available, I mean, some people use large diameter PMMA lenses for sulcus fixation. Of course, here you have a drawback, that's the incision size. And in the United States, there are not many opportunities available here. One of the lenses that's mostly used is this large diameter 3-piece silicone lens. And the lens has an overall diameter that's large, an optic diameter that's large, and has optics edges. They are very smooth and round. And I would like to highlight to you that actually silicone lenses have a very highly hydrophobic surface, and usually the results with this lens are actually quite good. So in other markets, not yet in the United States, there are lenses that were specifically designed as a sulcus fixated intraocular lens to be used as add-on intraocular lens. So I would like to comment a little bit about this single-piece hydrophilic acrylic lens, which is the Sulcoflex manufactured by Rayner. And the reason is that the design of the pinhole lens is moving towards a design that's quite similar. And one important thing is that even though that lens has all the appropriate characteristics and the lens is hydrophilic acrylic, I never really believed that pigmentary dispersion would be zero. So recently we had the opportunity to actually confirm that, because we had 2 Sulcoflex lenses that were explanted because of calcification. And these were eyes that were very complicated eyes. They received the Sulcoflex, but they had to undergo the MAC and rebubbling, a lot of intracameral injections of air, and a lot of secondary procedures. The lenses end up calcifying, they were explanted, and by checking the lenses very carefully, we could observe in the loops of the lenses some degree of pigmentary dispersion. So this was not causing any clinical problem. The explantation was done because of another issue, but it's just for you to know that it's probably not going to be zero in any way. So I wanted to comment on this first study we did some years ago on the Sulcoflex. Basically used pseudophakic human eyes obtained post-mortem that had already in the bag IOLs. And these were eyes that were of different sizes. We selected eyes with different IOLs in the bag, so different thickness of optics, different amounts of Sommers ring formation, and then we wanted to see, by putting the Sulcoflex, how this would look with all this variety of eyes. So we evaluated them before implantation of the Sulcoflex with some imaging technique, then the lens was implanted, then we re-evaluated the eyes. And for example, you have here, after the add-on implantation, the lens fixated in the sulcus. So here, this eye has a single-piece hydrophobic acrylic lens that's quite thin. This eye had no Sommers ring formation, so appropriate centration, no tilt, and a distance between both lenses. In this case, this is the eye that I just showed you the ultrasound images. So you have the in-the-bag IOL, and then you see the loop of the Sulcoflex lens actually going to the sulcus. Here is another example. So you have an eye with the same type of hydrophobic acrylic lens in the bag, and in this eye there was a lot of Sommers ring formation, so quite different, and Sulcoflex is there, appropriate centration, no tilt, and appropriate distance between the lenses. And here is that same eye. There is so much Sommers ring formation that you actually cannot even see the sulcus fixated lens. And another example that's quite different, because this eye turned out to be implanted with a plate silicone lens, and you can see how thick this optic is, but yet with the implantation of add-on lens, you still have centration, no tilt, and you have distance between both lenses due to the convex-concave characteristic of the optic. And here you have this eye. I just show you the ultrasound. You cannot really see the lens in the sulcus because of the Sommers ring. So what we wanted there is to have all these kind of situations that add-on IOL could face, because this would be a variety of patients, pseudophakic patients. And now we had the opportunity then to do a similar study with the pinhole lens. Here I'm just showing the latest version, and you have the large diameter, and it has the thin loops, the undulated loops. But actually in this study that we did, we had the opportunity to compare 2 versions. So we had a very early version, which is that one that's much thicker with the 3 loops, the tripod design, and we compare with this open loop, thin loops version. So we obtained these human eyes from eye banks. So these were eyes from patients who had cataract surgery before they died. And these eyes were implanted with different lenses, at different lengths, postoperative times, different summary ring formation, so a variety of situations. And then we imaged these eyes before and after the pinhole implantation. Just to give you an idea about the type of eyes we analyzed, so we have very thin lenses, hydrophobic acrylic lenses, and we had silicone lenses that are much, much thicker. We had three-piece designs, plate designs. We had summary ring formation that was very, very dense, almost calcified, and other eyes with much less. Some eyes didn't have anything. So again, a variety of situations. And here you have some results. So this is before the pinhole implantation, and then in each eye we put one version, remove and put the other version at different orders. And here you have, in both cases, you have appropriate centration, no tilt. You can appreciate how much thinner the new version actually is. So in this case here, very good results with both. In this eye, it was actually very interesting because with the new version, no decentration, no tilt, and we analyze, of course, different meridians. And with the oldest version, what happened here is that there was in this eye a localized area of zonular fragility. So actually one of the closed loops entered that zone and ended up behind the ciliary body. And when this happens in some meridians, so here you don't see any tilt, but here you actually see some tilt, although the centration was still very good. So here is just for you to see from an anterior view how the loops fixate to the ciliary sulcus, and you have here the lens in the bag in both cases. This is a single piece hydrophobic acrylic lens. This is this three-piece silicone lens, and here you have the new loop in the sulcus with a much larger area of contact. And here from a posterior or Miyake apple view, it's very interesting to see because this eye has almost no summary ring, pretty much no summary ring, and you have the single piece hydrophobic acrylic lens in the bag, and you can actually see, because the lens is black, you can see the lens in the sulcus, and the loops disappear here, of course, because they are appropriately in the sulcus. And in this case, with a localized area of zonular fragility, actually this loop ends up being posteriorly. Lens is still centered, but in some meridians you see some tilt. So we do believe that the current platform actually may have some advantages. And you have, of course, a large optic diameter. This may help reduce any risk of optic iris capture. The large diameter of the undulating haptics allow for IOL centration, rotational stability, of course the polished round edge, the undulated haptics. All of these characteristics will minimize tissue contact reaction, although again we do not believe pigmentary dispersion is going to be absolutely zero. Have the posterior optic haptic angulation that provides UV clearance, decreased risk of optic iris capture. The optic configuration, by being concave convex, avoid then the contact between the two IOLs, the IOL in the bag and the add-on IOL. So all of these anatomical considerations are very important because this is the platform of the optic of the lens that has very special characteristics which are largely being described here. So thank you so very much for your attention. If you have any questions.
Thank you, Liliana, for this tremendous job. It's an amazing amount of detail put into such a small piece of acrylic, and this gives an amount of information that we all need to improve IOLs, and I'm sure that many of the improvements we see in IOL technology depend on your amazing work there at the Moore and Eye Institute. So really, thank you for your help. So I guess in summary, the reputation of single-piece IOLs in the sulcus, as shown by Liliana, is not good. And the main differences here from IOLs that are designed for in-the-bag implantation is the angulated haptics, the thin and rounded profile of the haptics, and the round optic edge and the larger overall diameter compared to most IOLs. So let's get back here to another case. This is a 61-year-old woman who was not happy with the result of a recent cataract surgery. She was told that prior to cataract surgery, she needed to have her cornea regularized with corneal ring segments, which she did. And after cataract surgery, she didn't notice much improvement. So she was not happy, and she came for an opinion about her case. And of course, I showed cases with large pupils and damaged iris, and this is a normal iris and a normal pupil. So the obvious question here is, how small does a pupil has to be so you could indicate this procedure, or what is the lower cutoff size for pupil size? And here we don't really care much for the number itself, and what we use to indicate the surgery is the improvement seen on the pinhole acuity test on top of the best spectacle correction. And but of course, the size of the pupil is important, and we've seen patients with pupils small as 2.5 millimeter having a good improvement here with this device. So in this case here, the Pentacam examination shows a relatively small pupil, or a normal size pupil. But the Pentacam is not ideal for pupil measurements because it's performed with a bright light source in front of the patient. And the ideal equipment that we considered for this task is the topographer made by Oculus, which is called the Cataract. And what it does, in every device that intends to measure pupil size, it's pretty much an infrared camera. And with an infrared camera, the eye does not detect the light source, but the camera will show an image. And in this topographer, the device shines the placido rings with a white light, and that simulates changes in brightness during the day, and it will present the results in the form of a graph here in the bottom half of the slide. It will show the pupillary response to the light being projected into the patient's eye. And so this is, in my opinion, the ideal equipment to see the pupillary response for light. And we do our measurement in a different way. We had a modification done at our Hogstrite slit lamp. And what we did here on the top of the slide, you can see that the halogen light bulb was removed and replaced by an infrared LED. And this infrared LED, when it is turned on, the patient sees no light because the human eye is not sensitive to infrared light. And we attached an infrared converted camera to the slit lamp. And this camera does detect the light that is being projected by the LED. And when I say an infrared camera, what is an infrared camera? Well, normal cameras, most normal cameras, they have a silicon sensor, and those sensors are sensitive to both visible light and infrared light. And for normal purposes, you don't want your picture to have an infrared interference. So there is a filter over the infrared portion of the spectrum. So an infrared camera, the one thing that is done here to become an infrared camera, you have to remove the original filter and place another filter in front of the sensor. And this new filter will block all visible light and allow the infrared light to pass through the filter. So this is what we do with this infrared camera attached to the slit lamp. And with this modification, we see we record a video of the patient's pupil with different lighting conditions. This is an older patient with senile meiosis, and here you can see when the room lights are turned off or turned on, there is a small amplitude of dilation, which is typical from older patients, the loss of amplitude of pupil dilation, which is completely different from this 40-year-old woman who really has a huge pupil even with the room lights turned on. And when we turn the lights off, there is the pupil gets slightly larger, and when we turn on the lights, there's a pupil snap, but the sphincter does not sustain the contraction. So this is a very interesting case for this new technology. Is a patient with a huge pupil, and I think pupil size is totally underrated in ophthalmology, and especially because when we are examining in a slit lamp with a bright light in front of the patient's eye, most pupils look the same. They behave pretty much in the same way. So just going back to our case here, this keratoconus patient with intrastromal ring segments and unhappy with her vision. So in this case, here we see the implantation. The device is very, very thin, and this is why we have to avoid complications during implantation. And we're going to go over the ideal injector. But here it's a very simple technique with a 2.2 millimeter incision, and here the device being rotated into the sulcus. It is important to put some OVD behind the iris and try to see the anterior movement of the iris. So this way you would avoid an in-the-bag implantation or accidental implantation. You want to keep the iris anterior and the capsular rim posterior, so you would create more room for the device. So this is the aspect of the eye at the end of at the day after. And the patient was very happy. Here we see with a bright slit lamp, the pupil is not that big, but this patient, she reported a great improvement in visual acuity, and then she was very happy. This is the uncorrected vision from an amazing improvement, and she further improved with spectacles. So this again is a case with a normal pupil, a relatively small pupil, and which had improvement with the pinhole. So an important question when you talk about this new technology is, what's the impact in night vision? Because you're restricting the amount of light that is getting into the eye. And when we talk about pupil size, we have to remember the work of these two physicists, these British physicists, Walter Stiles and Brian Crawford, who in the 1930s, they published this amazing study where they were studying the influence of pupil size on traffic accidents, which were becoming more prevalent at that time. And what the Stiles-Crawford effect states is that dilated pupils achieve a lesser degree of visual response per unit of light than contracted pupils. That means that small pupils are more efficient in terms of visual response. And that has to do to the directional sensitivity of photoreceptors. So, in a more practical standpoint here, when we have a dilated pupil or a larger pupil, the light is oriented in a more oblique way into the photoreceptors, and a certain amount of light will generate a visual response. And when we bring the pupil down, the light is oriented more parallel to the photoreceptors. And this unit, this amount of light, will generate a much greater visual response. So this is why. And so the Stiles-Crawford effect says that when you have a 30 millimeter, squared millimeter pupil, and you have one light bulb on, you generate a perception of brightness. And we expect that by reducing the pupillary area to 1/3, we expect to have the same brightness with the threefold in light energy. And this was not observed by those two physicists. They saw that with only a twofold increase, the brightness perception was already matched. So again, dilated pupils achieve a lesser degree of visual response than contracted pupils. And another statement related to the Stiles-Crawford effect says that the most important, the most efficient portion of the pupil in terms of luminance efficiency is not the center of the pupil. It is slightly deviated to the nasal side. So this is the most noble point of the pupil. And here we see the graph with this deviation towards the nasal side, which has nothing to do with angle kappa. This has to do with the luminance efficiency. And here, when we see a result like this, we might get very proud of this perfect centration. But in a case like this, we are certainly using a more noble portion of the pupil. And this might be better for the patient. So talking about low light, I'd like to show this case. This is a very interesting case. This 67-year-old man had RK performed, radiokeratotomy performed many years ago, and later on he had cataract surgery, but he ended up depressed after cataract surgery. He was totally unhappy with the result. He says that his vision got worse after cataract surgery. And here we see the radial cuts and a combined problem, multiple round opacities caused by foreign bodies in the central cornea. And just note how the pupil size in relation to the RK optical zone. Of course, this patient is unhappy, and we decided to perform surgery. And in this case, we used the preloaded injector, which was created by Dr. Bob Morcher. And with this preloaded version, it becomes a no-brainer. You simply push the plunger, and this is a less than 5-minute surgery. And this is the aspect of the eye the day after. And the patient was very pleased. This is the result in visual acuity. And he wanted the same thing done in the fellow eye, which was very similar, with the RK cuts and some round opacities, and we did. So this is the second patient with bilateral implantation. And for our surprise, he does not report any darkening in vision. And he even says that the greatest improvement is observed at night, when he's driving at night, because that's when he had the worst glare. And so this is the result after surgery. And this is the visual acuity. So here we see a bilateral implantation, and to our surprise, this patient did not complain of any problems of night vision. So again, our explanation for that relies on the Stiles-Crawford effect, and with this small pupil, the luminance efficiency is greater. So of course, many of you are thinking, oh, okay, I just want to see the contrast sensitivity values at night to really be confident that this has no impact in night vision. And I will show you, but remember that those patients are very hard to perform contrast sensitivity measurements, because this is a very sensitive examination and you really need a sharp vision to do this. And in those patients, the examination is truly not reliable. It's always a really low contrast sensitivity before and after. So I'm going to present the data here from a second group of patients, the group of pseudophakic presbyopia, which we will present the results. So here's contrast sensitivity before and after. This is the day scenario with 85 candelas, and here at night. And this reduction is not statistically significant, and it's in accordance to our clinical findings. So we will go over those results with more detail, but I want to just show this paper. And recently, pinhole optics has been used as an alternative to the correction of presbyopia, both in the cornea and inside the eye. And comparing the results of the use of pinhole and the modulation of spherical aberration as a way to improve uncorrected near vision. This paper shows that the results with small pupil profiles are more reliable and more predictable and better than the use of spherical aberration as a way to improve near vision. So I'd like to invite Bruno Trindade to talk about his work with pseudophakic presbyopia using this pinhole optics.
Thank you. Good afternoon to everyone. Actually, it's a pleasure to present today our unpublished data on these patients that we've done for presbyopia, to treat pseudophakic presbyopia. And obviously, it's a very well-known fact that by reducing the aperture, you get an increased depth of focus, and photographers rely on that effect all the time. So it's nothing completely new, and everything that we kind of see, it's sort of expected from our previous knowledge. So basically, we've done 15 patients who were bilateral pseudophakic. Most of them were females. That was the age range, and basically they all had near emmetropia subjective refraction in both eyes. All eyes were 20/20 and JAGA1 with correction. We performed the implantation in the non-dominant eye only, and we have a mean follow-up of 15 months to date. These are the initial the results for the monocular tested uncorrected near vision. So as you can see, most of them after implantation have pretty good uncorrected near vision with the single eye, and that gets obviously even better if we consider both eyes implanted, with almost 2/3 of the patients being able to read JAGA1 line. As shown prior, contrast sensitivity has absolutely no difference between before and after the implantation of this new device, both in photopic conditions and mesopic conditions. No statistically significant difference was observed in either testings. And we performed a questionnaire, a modified questionnaire, to identify subjective spectacle independency on those patients, and the answers that we've gotten were that there was a statistically significant or more independency in spectacle use after the implantation of the device with this subjective questionnaire. And if we break the questionnaire into 3 different ranges of vision, far, intermediate, and near, all 3 of them were improved as perceived by the patients, and this difference was statistically significant for both the intermediate and near range of vision. And this is actually the most important slide in this presentation, in this quite short presentation, is the defocus curve observed on the eyes both before and after surgery. And as predicted, there is a flattening effect of the defocus curve caused by the pinhole implant. And by doing that, we tend to extend the depth of focus and tend to improve the near vision of these patients. And obviously, the implantation on these patients were done after the cataract surgery. So we basically had absolutely no control onto what sort of spherical equivalent refraction that we had prior to the implantation of these pinhole. But obviously, we can also do the implantation of this technology as a primary procedure combined with the cataract surgery. And if we do go onto that road, we tend to obviously recommend to induce a little bit of myopia, or to induce maybe 3/4 to a full diopter of myopia, and that way we'll shift the defocus curve to the right, and that will give a summation effect of the flattening effect of the pinhole, plus the increased myopic range of vision as well. So, and most important, the distance visual acuity, endothelial cell count and stereopsis remained unchanged if we compared before and after surgery. No ocular inflammation, no ocular hypertension, no visual field related complaints, and very minor nighttime vision complaints were noted by just a few patients, but they were all extremely pleased with the results. So in a very short and brief conclusion, the implantation of this supplementary device was shown to be safe. Improvement of uncorrected near vision was noted and sustained over time, and it provided a wide range of unaided vision for these patients as well. So, yeah, thank you.
All right, any questions, any comments on this application?
I'd like to ask you about the importance of the centration of the pinhole.
Well, what we find, there's a slight amount of small decentration inside the pupillary area, but we found it to be very forgiving. We don't see many differences related to the position, and in theory, we always try to use the more nasal side of the pupil, but it ends up being centrated in the center, the geometric center of the ciliary sulcus, and we don't have much control of that. But we find it very forgiving. It doesn't really change much with the position. But yeah, so this is our experience with this.
What's your preference to the is horizontal, vertical position of the lens?
Well, we usually try to see at the end of surgery if it sits well, and if it's tending towards one direction, we do a rotation. But well, there are not as many studies about the proper diameter of the ciliary sulcus in different meridians, and we found it to be varying. Sometimes it's better to implant it in the horizontal, sometimes in the vertical. But in theory, the vertical meridians are slightly larger. So if you want a snug fit, you should orient it horizontally. But it depends. We don't really trust on those measurements, and we try to orient at the end of surgery and try to guide with our.
Sorry, is it commercially available and there's zero bracket?
No, it is not commercially available anywhere. It will start. It will become available in July, and that's for probably just for the European market. And but as said by the manufacturer, the CE mark will become available in July. So that's the expected date of introduction.
I'm sure you know that I thought about using the same idea with lenses with power for primary implantation.
You mean that the pinhole with?
I mean the pinhole
with power. Well, yeah. This was thought out, and this has been introduced by other companies, like a masked IOL. But we found that with this approach, a secondary approach, we can use in patients that have already been submitted, that had cataract surgery already, that already have an IOL inside the eye. And usually those patients, they're not refractive. You don't want to zero out the refractive error. You just want to improve, and then you can correct with glasses on whatever. The major problem here is trying to get rid of the high order aberrations. But it is an alternative to have a masked IOL, but it's not this concept that has no refractive power, and it'll be just the diaphragm effect. Well, I think we're running short on time here. So these are two cases with the previous version of Pinhole. This is a post-PK patient with corneal ring segments. And I'm just going to run quick over those patients because we're not going to have time for all of these cases. And this is a post-RK patient and with irregular astigmatism. So of course, this is not new technology. We must remember of the simple methods of reducing pupil size, either with pinhole glasses or pinhole contacts, and even pilocarpine. And when we talk about miotics, we have to remember of just some side effects that might be important here, and most especially retinal detachment. That is a big ghost, especially in myopic patients and in pseudophakic patients. So this is one thing to be considered, but it is interesting maybe to prescribe a pilocarpine treatment just to see to simulate the results, and one must be aware of the risks associated with that. And again, this has been introduced by XtraFocus and a masked pinhole IOL, and we must give credit to those who are doing work with pinhole implants. And this is a iris fixated diaphragm, also used for a post-PK patient. This was published sooner. And we must remember of this project by Dr. Vorosmart from Austria that dates back to 92. And this is a masked IOL which was developed by Morcher back then. And so it is important to know that. And another important question here is the influence on visual field. And this has been studied by many authors, especially the influence of pilocarpine in glaucoma patients. And there is a agreement that the reduction in the pupil size will create a general depression of visual field, similar to that resulting from decreased brightness or size of the test object. So, but this is absolutely clinically irrelevant in those patients. And that has to do to the position of the pinhole very close to the iris plane. And of course, if you have a pinhole occluder, and if you have a distance from your eye, that will have greater impact on visual field. And once you bring it closer to the iris, this will reduce. And here we see our results, which are in accordance to the literature, a slight decrease in overall sensitivity. And another important question is how to examine the retina. And here you can see with a slit lamp, you can use those small pupil lenses to see the fundus with some difficulty, and even those scanning laser ophthalmoscopes, which can get a wide view, but they require a slightly larger pupil. But this is where the material of this device, which is transparent to infrared light, plays a major role. And with our modified slit lamp, we can see structures behind the device. Here we see the toric marks of the IOL inside the capsular bag. And in this case was interesting. It was important to see if there was any rotation in the IOL during the pinhole implantation. In this case here, we can see something was migrating into the visual axis. And with infrared imaging, we can see that those are Elshinic pearls, and at that moment we decided not to do anything. And there is Topcon makes a infrared imaging module called the BG4M, and here we see other applications of such devices. And here with an OCT we can see the capsular rhexis behind the device, and we've seen this. And with different lenses attached to the OCT, you can get a pretty wide view, up to 160 degrees of field of view in composite view. And here, with YAG lasers, since YAG lasers use infrared light, you can perform capsulotomies even through the black occlusive part. Of course, this is not important because you can shoot through the pinhole, but still you can shoot through the black occluded part because that's infrared light going through the black, which is black for us, but not for infrared light. And I'm sorry I'm having to rush through this, but it's just so we can show everything. And in terms of injectors, we want to avoid those flat rod tips. The tip of the rod, if it's too flat, it'll go under the device because it's so thin. So when you're using these, you can still use flat injectors, but you have to push the device down, and it's harder. We prefer cylindrical rod tips, such as silicone tips. And here we see a flat rod tip advancing underneath the device, and that can lead to amputation of the trailing haptic when it exits the injector, because the rod and the haptic, they're both competing for the same exit. So this is our preferred injector. It's made by Medicel. It goes through a 2.2 incision. It has a coated interior, and it goes well. And of course, because of the angulation of the haptics, we must pay attention to the orientation, and we should always use this Z orientation instead of an S shape. And here we see a case of a mild keratoconus, and this patient had a terrible experience with a phakic IOL. He had an acute spike of IOP in the first day and had the IOL removed, but he ended up with this fixed mydriasis, and later on he developed this dense cataract. And we decided to operate this with the pinhole and primarily implanted in the sulcus. And then it would be it would solve two problems, both the large iris and the mild keratoconus. And here at the end of cataract surgery, we had one IOL in the bag. It was implanted with forceps, a 3-piece low-powered lens. And on top of that, we did a primary piggyback implantation. However, things did not go as planned. And the device went upside down. And here we see it being tucked. And beside our effort and our attention, we had a twist of the injector. So the only thing you have to pay attention here, you see the trailing haptic in an S orientation. So this is upside down, and this would be a huge problem in a patient with a normal iris. In this patient, because he has such an atrophic iris, we decided not to rotate or not to do anything. Try to use it upside down. And of course, I'm not suggesting this to anyone, but this was at least it happened in a patient with a really damaged iris, and this is the aspect at the end of surgery. And this patient, the day after, he was emotionally happy. He said that he never saw anything like this, and this was at least we were happy with that, and we decided not to flip this lens over and just keep a vigilant follow-up of this patient. And so far, he had no further problems, and he's still very pleased with his vision. So again, to avoid this upside down problem, you just have to take a look at the haptic going to the left. The leading haptic has to go to the left. If it goes to the right, you have to flip it and continue implantation. So I would just like to invite Fernando for one last case, and this will finish our course, and is a very interesting case. We have to rush a little.
Do you recommend doing yak capsulotomy before implanting
Well, if there's any sign of CAP4 plastification, yes, but I wouldn't do it unnecessarily just to avoid, because you still could do it. And we've done it with the pinhole inside, and it's not a difficult thing to do.
Good afternoon. Well, this is a different case. Actually, it's an off-label application of this new promising device, if you will. This pleasant radiologist present for cataract surgery in her right eye. She had a history of keratoconus in both eyes and used to wear contact lens for a long time in both eyes. In the left eye, she used to she had cataract surgery and an implantation of this lens with a very good outcome. This is the aspect of the right eye with cataract. And the first, actually, her previous doctor had recommended her to implant cornea rings for the correction of her irregular corneal astigmatism. And then, at a later date, proceed with cataract surgery. But we decided to do something different in this patient. Here you see the pentagram map showing the obvious signs of keratoconus. In keratoconus, as everyone knows, the K readings vary a lot, which makes the IOL power calculation very hard and not very accurate. So for this type of lens, MA 60 MA lens, IOL Master recommended or predicted a -4 lens for betropia. But we decided not to implant any lens in this patient. We decided to implant this device, which is originally meant to be implanted in the sulcus as a secondary, as a piggyback implant. So we decided in this case to implant this device in the bag and leave the sulcus for secondary surgery if needed. We thought of implanting a sulcoflex at a later date if the patient needed. So surgery was done in the usual fashion. Actually, we created the Cataract a little bit bigger than usual to facilitate the insertion of the device in the bag. And this is the implantation. Well, the material is very nice. It has this property of being invisible, being opaque to visible light and totally transparent to infrared light. And the central opening is 1.3. So it here shows how easy the implantation is. It's very thin, so it was easily accommodated in the bag. And this is the aspect of the eye, the end of surgery, well, nice, centered in the bag. So the aspect of the implant the day after, you're going to see it right now. This is the eye the day after. The radiologist was quite happy with the result. So in this case, the supplementary lens was not necessary. The patient was very happy with the result. And if we had implanted the -4 lens suggested by the IOL Master, this patient would have ended up overcorrected, should have ended up hypermetropic. So this was a very interesting case in which we implanted this device in the bag without any supplementary lens. And this is the final result, very nice uncorrected vision. And the patient is very happy. She's working for the first time without anything, without contact lens, without anything. She's actually she's overjoyed. So this concludes my presentation. I thank you for your kind attention. Thank you.
Oh, excellent. This actually concludes the course. And thank you for your presence. And if you have any questions or comments, and I really hope this becomes available as soon as possible. This has been our tremendous effort to bring this to the world as soon as possible, and most probably in July it will be available.
Have you had any retinal complications where the lens had been removed?
No, we had one explantation. It was in a post-traumatic case with a severe sulcus anatomy variation, and the lens was totally decentered, and we had to explant. But no, we had no cases of retinal pathologies. But in case it occurs, I think there is no other way of doing anything except explanting it and treating it. So this window of infrared transmission is useful for following up. But it's always recommended to perform a really detailed indirect ophthalmoscopy before implantation and treat any pre-existing pathologies, just to avoid any future problems, which we haven't had. Any questions? All right. Thank you very much for coming.